All right, my friends, thank you so much for joining today for today's Tuesday topic on the thyroid hormone and critical illness. My name is Barbara McLean. I'm a critical care program specialist at Grady Memorial Hospital, and I'm really happy to come to you today from my new office. You can see I have a great window behind me. It's very fantastic. So just to remind you to keep in mind that you will always see endocrine emergencies at some point. And actually, you probably see them a lot more than you realize. You probably see them almost every day in your critically ill population. Just might not know it at the time, but always be thinking about it when you find that you have a patient who you can't get their blood pressure down or you can't get their blood pressure up. They have bradycardia and hypotension, bradycardia and hypertension, or the reverse, tachycardia and hypertension or tachycardia and hypotension. At that moment, you should always consider the possibility that the patient may have some significant endocrine dysfunction. Now, our purpose today is to talk about the thyroid gland in critical illness, and we're going to talk about a couple of different things. And then I'm going to end on what I think is the most common issue that you and I see all the time in critical care, and that's what we call a non-thyroidal inflammation syndrome, or it used to be called, and still might be in your area, euthyroid 6 syndrome, which is very common. Actually, about 86% of patients in critical care who have stayed in critical care for more than 2 days and who are receiving vasoactive drips, it's not at all uncommon to see this non-thyroidal inflammatory syndrome. So really important for us when we're thinking about our patients and how vital it is for us to appreciate endocrine function. So I'm a simple girl, just to make it really, really simple, just to make it simple for us and in our application, just to remind ourselves, at least very basic understanding in endocrinology is that you either have too much hormone or too little hormone. Great. Well, that's pretty straightforward. Too much, too little. Now, hormones come from a lot of different places, from the hypothalamus, from the pituitary, from the target organ, and then they have to act at the cellular level. So there's a lot of evaluation that has to occur, but we always want to remind ourselves that if the hormone is too high, we're going to need to suppress it. And if the hormone is too low, we're going to stimulate it. So those are pretty basic philosophies when we talk about endocrinology and as it applies to critical illness. So now we're going to just make it just a little bit more intense. But remember, today our purpose is really to talk about the thyroid gland. So first and foremost, I want to remind you, the hypothalamus actually controls the pituitary gland. So the hypothalamus is actually going to utilize a hormone called thyrotropin releasing hormone, TRH. That TRH released from the hypothalamus, which typically you are never going to see and you're not going to measure, that stimulates the pituitary gland. The pituitary gland releases thyroid stimulating hormone. Thyroid stimulating hormone travels in the blood to the thyroid gland, and the thyroid gland actually puts out both an active and an inactive form of thyroid hormone. So starting with the hypothalamus, which regulates the pituitary which stimulates the thyroid gland, and the thyroid gland, which then releases active and biologically active and inactive thyroid hormone. Now, it's really important to remember thyroid hormone has so many responsibilities, but for us, we're talking about our basic critical patient. What we're actually going to communicate when we talk about the thyroid hormone is the ability to be responsive to catecholamines, like norepinephrine and epinephrine, and to actually maintain normal metabolism, most particularly normal glucose metabolism, and also regulation of some of your ionic regulators like sodium and potassium. So first and foremost, what we're going to think about is a picture of a patient in health, and then a picture of a patient in critical illness, and thinking about all the things that you might be doing at the bedside. Like you've got a patient with refractory hypertension, and you're using beta block therapy, using calcium channel antagonists, et cetera, can't get their blood pressure under control. You should think first, is this a thyroid problem? When you have a patient who's profoundly hypotensive, who's also relatively hypoglycemic, perhaps even bradycardic, you should think, is this a thyroid problem? Now, you don't need to be diagnosing the patient. You don't have to actually understand all of the testing, although it's helpful. You just need to have a discussion. Is this a thyroid problem? Now, if we just remind ourselves about vascular tone and the control of vascular tone, we always remember that vascular tone is, first of all, regulated by the vasomotor center. That actually is at the connection of the spinal cord into the brain, the medulla oblongata, and that's really part of the cardiovascular center, and that's what helps us to maintain vasomotor tone in all of our vessels. And those vasomotor fibers are most particularly part of the sympathetic division of the autonomic nervous system. The impulse travels along the fiber, starts short of the receptor site, is carried across the receptor synapse by the neurotransmitters, either norepinephrine or epinephrine. And it's really important to remember that it's the hormonal response and the hormone integrity that allows us to respond to our catecholamines. Of course, that's norepinephrine and epinephrine, but it also is synergistic with the thyroid hormone. So always incredibly important for us to consider when we have patients with refractory hypotension or refractory hypertension, meaning neither on either end is the patient responding to your traditional therapy. You always want to think that there may be a possibility of an issue with our thyroid hormone. Now, again, we just remind ourselves about those connections between the vasomotor center and the hormone and the target organs and what that actually means in terms of relationships. Okay, so very important to remember, endocrine is different than nervous system, right? Because it's a chemical communication. And we think about the glands that are regulated, controlled, and distributed throughout the body, and that those glands include the adrenal glands, the pituitary gland, the thyroid gland, etc. But all together, whenever we're looking at those glands, we remember that they actually help us to regulate our metabolic function. And I always like to look at the 5 components when we talk about endocrinology. The gland, and in this case, that would be first gland would be pituitary. And then the second gland will be the thyroid. The hormones that communicate between these glands, so from pituitary to thyroid, that would be the thyroid stimulating hormone. And then that'll regulate the thyroid gland. The thyroid gland will release primarily T3 and T4, T3 being metabolically active and T4 having 4 iodine chains on the molecule and inactive. Those are released into the circulation, and traveling in the circulation, they will reach the target organs. And when that hormone answers the target organ request, the response will end. Of course, that's called a negative feedback loop. Now, lots of different glands participate in physiologic stress response. And again, what we're going to think about here is the thyroid gland, but the stimulator and the terminator of the communication. The stimulator for the communication to begin, the terminator for the communication to stop is the cell. It's the cell that is requesting the hormone, and it will be the cell that says, I've had enough hormone. So stimulator and terminator is ultimately the cell. All right, so that's just a kind of a very, very quick down dirty, just the smallest amount looking at overall endocrine function when we're talking about critical patients. So now let's look at the beautiful thyroid gland. I love this. I actually have to say, I never think about the thyroid gland with the right and left lobe. The right lobe of the thyroid gland, no surprise here, is called the dexter, right? That's dexter always means to the right. But the left lobe is called the sinister lobe. Not sure why it's called sinister. I'll have to research that more. There might be a reason. Don't know what it is. So the right lobe and the left lobe, and those are clearly surrounding the trachea, of course, as we all know. Now, that beautiful thyroid gland is in the shape of a butterfly, and it's located at the base of the neck. Remember, it's controlled first by the hypothalamus, which regulates thyrotropin regulating hormone. The hypothalamus regulates the pituitary, and the pituitary then stimulates the thyroid gland with TSH. So TSH is a pituitary to thyroid regulation. It is the largest endocrine gland, second largest gland in the body, but the largest independent gland, 20 grams in an adult, big lobes with that little division or the connector, that's called the isthmus. And it's actually named for its relationship to the laryngeal thyroid cartilage. Some folks say it looks like a Greek shield. Others say it looks like a butterfly. I don't really know what a Greek shield looks like, so I can't say that. It does look like a butterfly, although, albeit maybe with a small abnormality or defect. So very beautiful gland and snuggled beautifully at the base of the neck on either side of the trachea. Okay, now we're going to just think about some of the things that we'll see. And really, it doesn't matter whether you are measuring all of these, although they are essential when we're really trying to evaluate what's going on with the thyroid gland. For most patients, and particularly for women, TSH, thyroid stimulating hormone, which is a pituitary output, and free T4, which is a thyroid output. Most of us look at TSH and free T4, and if those are normal, we think things are okay. What I want you to see here, though, is in critical illness, and by the way, in particular, in non-thyroidal response and critical illness, again, that used to be called euthyroid 6 syndrome, what you actually see is a severe decrease, a mild to severe decrease in free T3. That would be FT3. Also, you're going to see in critical illness a significant increase in RT3 or reverse T3. So look at mild illness, free T4 is normal, TSH is normal. Moderate illness, free T4 can be normal, TSH can be normal. It's only until you're severely ill that you start to see changes in what we look at most commonly, which is TSH and free T4. So with mild to moderate illness, whether it's thyroidal illness or euthyroid 6 syndrome, you may not see changes in what we most commonly measure, which is free T4 and TSH. What that means is that we as bedside nurses, if we have some suspicion about our patients, we may want to ask for a bigger bundle of evaluation. And, there's 20 or 25 measures that we can make surrounding the thyroid gland. All we're going to really look at here is free T3 and reverse T3. And remember that in critical illness, T3 goes down, and it goes down even in mild illness, and reverse T3 goes up. So these two, free T3 and reverse T3, are going to be really important and meaningful to us in terms of the way that we're looking at our patient's thyroid. Okay, so very, very important when we're thinking about our patient is to remind ourselves that T3 is really the active thyroid hormone. And that's because when we think about the thyroid hormone, it basically has 4 binding sites. All 4 of those sites bind to iodine, and T3 has released one of its iodine, which makes it actually physiologically active. And again, reminding ourselves that this actually is what is going to help control our metabolic rate. I'm so sorry, I forgot to shut my email, so you might hear a dinging every once in a while. Okay, so let's think about some thyroid disorders, and there's a lot of them. And the ones I want to think about here are the ones that we see commonly or somewhat commonly in critical illness. So there's many of them, right? But we don't see all of them when we're talking about our critical patients. So with hyperthyroidism, frequently what we can see is either thyroid storm or the most common, Graves' disease. Now, what that means is the thyroid gland is profoundly overactive. So by the way, whenever you talk about neurostorming, be sure you're not talking about neuroendocrine storming. Make sure that you've evaluated the thyroid gland and that you've ruled that out as a participator in the response that you see of a patient who has severe hypertension and tachycardia and hyperthermia. Always want to rule out that it might be thyroid dysfunction. So we're going to talk about thyroid storm and Graves' disease a tad bit more. And then we're going to think about hypothyroidism. There's a lot of different divisions of hypothyroidism. If you were taking an examination, there'd always be a question about myxedema and myxedema coma. But I want to remind you that there are other types of hypothyroid dysfunction. And in the critical care unit, the single most important one will be sick euthyroid syndrome or euthyroid 6 syndrome, or what it's now called is NTIS, non-thyroidal inflammatory syndrome, NTIS, all the same thing, all euthyroid sick or sick euthyroid gland. It just means that you don't really have a thyroid dysfunction, but that it's situational. So think about it, euthyroid 6 syndrome or NITS. Think about it like a person who has hyperglycemia, but they're not a known diabetic. It's the critical illness that propagates this abnormality, and we have to be paying a lot of attention to it. So we're going to think about the hyperthyroid side and the hypothyroid side and how that presents to us in our critical patients. So most of us, when we think about thyroid dysfunction, we think about those very far ends of thyroid dysfunction. We think about the hypothyroid patient who has severe, significant lid lag, a very taut skin, very buffalo skin, a big pasty appearance, big lips, big face, lid lag. And then the hyperthyroid patient who typically has thyroid eye syndrome and who has very significant exophthalmos. These are the kinds of things you see in your head when somebody's talking about thyroid dysfunction. But remember, we're thinking about not somebody who got diagnosed by their primary care that you obviously know there's something wrong with them. We're talking about the more subtleties that occur in the ICU patient. Okay, so if we just start with this basic division and we say, if you have excessive thyroid hormone, so you have an excess pituitary stimulation, perhaps the pituitary, excessive stim, the thyroid gland by itself has excessive release of thyroid hormone, or if you are, you actually don't have adequate protein binding, you might see hyperthyroidism in critical care. And when we think about that, these are really quite important. First of all, the patient will typically be hypertensive and tachycardic. And you might be giving lots of beta blockers and other types of therapy, trying to get their heart rate under control, trying to get their blood pressure under control. And you might see some response and then resurgence. It really is refractory, the tachycardia and the hypertension. In addition to that, you will have hypoglycemia, and that's because they're utilizing that glucose pretty aggressively. Now, that can change a little bit later, so don't rely on that solely, but tachycardia, hypertension, nervousness, palpitations, very significant sweating, high temperature, high temperature, high temperature. And then when you draw their labs, you might see, you probably will, a very low thyroid stimulating hormone. So remember, that's usually less than 0.01. So that's going to be very, very low. The thyroid stimulating hormone is almost suppressed because the pituitary is, whoa, thyroid gland, stop releasing hormone. And no longer does the pituitary wish to stimulate the thyroid gland. Now, these patients are super responders to catecholamine stimulation. That doesn't mean that you're giving them drips. It means that they have their own super response to catecholamines. That's why they're tachycardic and hypertensive and hyperthermic. Everything is fast, 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 fast. Completely reverse from hypothyroidism. So with hypothyroidism, the patient typically is going to be bradycardic and hypotensive. Now, we already know that's a signal that we have to pay attention to. Whenever you are hypotensive, you always expect to see an increase in the heart rate. So bradycardia plus hypotension, the most common thing is, did my patient have a pneumothorax? That's the most common thing. But after that, no reason to suspect a pneumo. There isn't a pneumo. You have synchronous expansion of the lung. Patient has persistent bradycardia and hypotension. You're stimulating them. They're not responsive. This is a really important key and clue that we're going to want to take a look at their thyroid gland. And typically, these individuals will have an increase in thyroid stimulating hormone if they have a primary thyroid problem, meaning the primary problems at the thyroid gland. TSH will be elevated. So, and the pituitary is like, wake up, thyroid gland, wake up, release thyroid hormone, come on. Everything is slow. Everything is slow. Despite all the therapy you're giving the patient at the bedside, they're going to be refractory to catecholamines. Now, every one of us, if we saw this person on the street, we might not always know what was wrong, but we would know that something was wrong. And of course, what this patient has is a significant thyroid producing goiter. Now, here's the problem with goiter. Lots of times you're going to see goiter on somebody who's hyperthyroid. You're also going to see a goiter on somebody who is hypothyroid. The difference is whether or not the tissue is producing thyroid hormone, but you can see a goiter in either disease state. So we're looking at this and we're not sure. We might see this person on the street, or they may be a patient admitted to us. We're not really sure quite yet what the problem is, but we're going to think about it in the context of the situation, right? So I see that the patient has a goiter. We may have you or one other person, probably not you, probably your provider, your APP, or your attending physician, maybe your endocrine fellow, are going to palpate that goiter. But only one person a day should be palpating a goiter, because every time you palpate the goiter, you're going to stimulate it. So, you know, we're in here at Grady, we're in a teaching hospital. Everybody and their brother is going to want to feel this. And every time they do it, they're stimulating that goiter. So we really want to protect our patients and say, hey, only one goiter palpation per day per customer. Thank you. Bye-bye. See you later. But we're also going to put it in context, right? I have my personal, this is not my personal picture. I have never seen a goiter this large. I've seen some big goiters. Okay. Now these folks are going to be there, despite the fact that they're always hungry, they're losing weight. They'll tell you, I've been eating a lot. I'm eating a lot of food, high calorie food. I just keep losing weight. Of course, their worry is that they have cancer, and that's why they're losing weight. And they present with tachycardia. Oftentimes they have a very overactive bowel. They have a lot of diaphoresis, and they're very nervous. Oftentimes will complain of palpitation. What's very important to remember is hyperthyroidism is one of the main causes of atrial fibrillation. So we have a new onset AFib. We're always going to consider, is this caused by atrial fibrillation? Oftentimes, because it's creating a very hyperactivity of the heart, you're going to have a very high output, cardiac failure. They may have venostasis of volume and they're in congestion, but they will have a preserved or accelerated ejection fraction. So they'll be hypercontractile, but now they're also going to actually have hypertrophy of the left ventricle. So they're going to have high output congestive failure with a preserved ejection fraction, but the muscle wall will actually be larger. And of course, we're going to identify that by echocardiogram. They also very commonly are going to have systolic hypertension. Also, one of the key signs for us will be that they have a widening pulse pressure, that's systole minus diastole. Because the heart is so hyperactive and because the contractile mechanism is so profound, their systolic pressures are going to go up. They're also going to have heightened vascular tone, so that makes the systolic pressure go up even more, which is why they often present with refractory hypertension. But what's really, really important when we look at these patients is that they very commonly are going to have significant hypernatremia. And that may be the biggest clue in addition to exophthalmos or that large goiter. Now, the exacerbation of hyperthyroid disease, which you may know you have, you may be being treated for, or you've never been diagnosed. The first time you come to the hospital, you end up in the ICU, you've never been diagnosed. But the extreme form of hyperthyroidism is thyroid storm or Graves' disease. We're going to talk about them as two different entities. An extreme form of thyroid poisoning, meaning you are poisoning yourself with thyroid hormone. It often is stimulated by a stressful illness, by thyroid surgery, and by cardiac surgery is a very common stimulant for this extreme form of thyrotoxicosis. Frequently, these patients are going to have very significant tachycardia that you will not be able to treat with beta block. You will not be able to treat with calcium channel block. This patient is not a candidate for adenosine, but sometimes people give adenosine anyway, even though the patient's not a candidate. But they're going to be resistant to therapy. Doesn't mean that you might not have an immediate drop, but you're going to go back up again, okay? Oftentimes, again, they have an overactive bowel, they have an overactive bladder, they're urinating all the time, they're having diarrhea, they may have vomiting, and typically they're quite dehydrated, hence the hypernatremia. They also will have typically a refractory temperature. So they may have a temperature, it's possible at the severest end that this could be a life-threatening temperature as well. The mortality rate of thyroid storm undiagnosed, unmanaged is extraordinarily high. Basically, your patient will beat their heart to death. They will metabolize themselves to death and they will burn themselves up. So that's a very severe form. Hopefully somebody has recognized this early on and they're really looking at what's occurring for this patient. So this is really a form of decompensated hyperthyroidism. And again, we're going to think about that tachycardia associated with congestive failure, tachycardia associated with a preserved ejection fraction and congestive heart failure, and then kind of mental status changes, agitation, confusion, delirium, profound psychosis, and then just thinking about the whole gastrointestinal system, the GIT, is you're just kind of, everything is actually revved up. So everything's turning over really fast. Patients may have significant abdominal cramping, they have nausea and vomiting, etc. Okay. Now, the most common form here of life-threatening thyrotoxicosis is actually Graves' disease. And by the way, here's a place where women are more equal than men because the ratio is 5 to 1. 5 women to 1 man will have an autoimmune disorder that presents as Graves' disease. Has a very strong hereditary component. So someone may say, yeah, my mother had hyperthyroidism, my mother had her thyroid taken out. They may not be able to say they had Graves' disease or anything such like that, but my mother had her thyroid removed. Diagnosis, even though we're going to use laboratory values, the diagnosis is mainly made by our symptomatology. So I wish this was mine. It's not. Someone else published this, and it's in lots of articles on endocrinology and thyroid, but we just look at these are the things you expect to see: GI hypermotility, rapid weight loss, apprehension, anxiety, agitation, volume deficit and a voracious appetite, exophthalmos and erratic menses, and systolic blood pressure elevated and sweating, all of which spells Graves. I wish I'd thought of it. I didn't, but it's really great because it kind of lines up all the things you're expecting to see in this patient population. Now, when you look at their laboratory value, if their primary problem, primary disease means the problem is the thyroid gland. The thyroid gland is hyperproducing thyroid hormone. That thyroid hormone is out there in the circulation and in a negative feedback loop tells the pituitary to shut down. So in primary thyroid disease, you're in primary hyperthyroidism, your TSH will be low because the pituitary is like, whoa, thyroid gland, you're way overproducing. Stop, stop, stop. So TSH goes down, but your thyroid gland is still producing the thyroid hormone. So your T3, your free T3 will be up, your reverse T3 will be down, and your T4 will be also elevated. If the problem is the pituitary, which it often is in critically ill patients, in a pituitary hyperstimulation, the pituitary gland is going to be stimulating the thyroid gland, even though you have adequate T3 and TSH. T4. Even though you have adequate thyroid hormone, the pituitary gland is still stimulating the thyroid gland, and that's secondary disease. That's disease of the pituitary. Okay. Exophthalmos, again, that's a really extraordinary thing. That exophthalmos is actually now we talk about as thyroid eye disease, and that actually comes from accumulation of fluid and other membranes that push the eye forward. And as you know, it's not just that you have big eyes, you can't close your eyelids. And it actually can lead to blindness. It's a very serious disorder. So a lot of times people say, oh, Bela Lugosi had exophthalmos. Well, I don't think so. I think he just had really big eyes. I think the question to ask would be, can you close your eyes? If you can close your eyes, the probability is that's not exophthalmos associated with hypothyroid disease. Okay, so number one, we shouldn't be messing around with this. We got to get an endocrinologist to come and see the patient. We're going to give the patient fluid. We're going to try to treat whatever their precipitating mechanism is. Are they septic? Do they have an infection? Do they have an open wound? And then we're going to try to target the synthesis of the hormone. Okay. We're going to use antithyroid medication. Most particularly, what we're going to do is we're going to use some type of iodine base to actually convert the active form of thyroid hormone to the inactive form by promoting iodinization of the thyroid hormone. So lots of different ways that you can do that. It just depends on the situation, who's seeing the patient, how quickly you have to work, and how quickly you have to block. The other thing that you can do is glucocorticoids, which actually block the transition of the less active form T4 to the more active form T3. So glucocorticoids will block that conversion of T4 to T3. So your expectation is you're going to give some kind of iodine base, plus you're going to give some kind of glucocorticoid. You might also give, of course, esmolol and propranolol are not glucocorticoids. You might also give some beta block therapy. Beta block therapy also blocks conversion of T4 to T3. So we're going to use beta blockers, we're going to use corticosteroids, we're going to use an iodine base to actually reduce the active form of the thyroid hormone, which is just a perfect way to treat the patients. Okay, so again, I'm kind of saying that same thing, right? I've already said it, saying it again. Block the active form of T3. So really, really important for us to think about this when we're looking at the bedside at a patient who has refractory tachycardia, refractory hypertension. We can't understand what's happening. We're given beta block. We're doing other kinds of therapy. We need to be questioning at that moment, is this patient actually hyperthyroid? Let's get a thyroid evaluation, and then we move forward from there. Okay, so some of the supportive measures that you're going to utilize for those patients is, of course, if they have a fever, you're going to try to cool them down. You can use cooling blankets. You could use an Arctic sun. You're going to give IV fluid because of their hyperthermia. They're going to be very dehydrated. And salicylates actually can promote more free hormone. Free hormone is going to be biologically active. So the choice is to avoid aspirin. I think all of us avoid aspirin anyway. We're going to use acetaminophen, okay? And again, we're going to think about steroids. We're going to think about iodinization. If you cannot control the patient and they continue with this persistent thyrotoxicosis, it is possible to do a plasma exchange. Now, you may or may not do that at your institution, and that may or may not be an option for you. And that is actually just to remove the active hormone from the blood. Okay, now let's go to the other side, hypothyroidism. So in hypothyroidism, that's really the inefficient or insufficient synthesis of thyroid hormone. And again, more common in women than in men. And the most common cause in women is Hashimoto's thyroiditis. It's an inflammation of the thyroid gland that causes a reduction in the efficiency of the thyroid gland. Also, we see thyroid failure when patients have received iodine-based dyes for any kind of therapeutic intervention or diagnostic intervention. And also we can see it after patients have been treated, particularly if they've had a thyroid gland removal for thyrotoxicosis. So I don't know how many of you know people who are hypothyroid, but I would just remind you that being hypothyroid all by itself is a very difficult spring colt to get your noose around, because your thyroid hormone is up and down depending on your bioactivity. And so when we give thyroid replacement, we're just kind of shooting into a big bucket of water. We don't really know whether that's going to be adequate or not. And at any given time, it might be inadequate. But when we remove the thyroid gland because you've had thyrotoxicosis, or you have a goiter, you have a cancer of the thyroid gland, we now have taken away all of your thyroid regulation. And now, again, we're going to be shooting in a bucket. So just want to remind you about thyroid supplementation, just a really little statement here. Should be done the same time every day on an absolutely empty stomach. So like many people that I know who are hypothyroid, they get up and take their thyroid medication at 4 a.m. They go back to sleep so that they've had the thyroid hormone into their system, into their gut for about 2 hours before they even have a coffee. So it's really important when we're teaching, when we're working with patients, to make sure that they appreciate and understand that. Now, I want to make sure you appreciate that wasn't thinking when I was typing. Amiodarone is one of the major agents that's associated with hypothyroidism. Now, typically, you're not going to see that when we're talking about the critical illness patient. We're using IV amiodarone, but patients who are on amiodarone for longer periods of time have converted to oral, they go home, now they come back and they have hypothyroidism. Amiodarone is an iodine-based agent. Now we think about signs and symptoms, right? So everything here is slow. Okay. So, So those patients frequently gain a lot of weight. They'll say to you, I barely eat, I'm not eating, I fasted, I'm doing this, I'm just eating lettuce, but they're still gaining weight. They're gaining weight despite what they're doing not to gain weight. They typically have an enlarged thyroid gland because the thyroid gland continues to produce cells to try to accommodate, to make more thyroid hormone, but these are non-productive thyroid cells. They often are very depressed, have a very high sensitivity to heat and cold. Oftentimes they get confused for Raynaud syndrome. Their hands are so cold, their feet are so cold. They frequently are very fatigued. They can have hypoglycemia. And because of the alteration in their metabolic rate, their cholesterol levels go up. Now, if you take a look at this, you can see why there's so much difficulty, first of all, in recognizing women in thyroid disease, first of all, because remember that women is 6-1 to men, but because women in their lives tend to have many, many activities, they're multitasking, they're oftentimes have neglected themselves, aren't exercising, eat what they can eat, a bag of potato chips, a cookie, a candy bar, and they're always tired. And the exacerbation of that, what I would tell you, and I think really serious, is postpartum. What we know now is that there is a significant incidence of postpartum hypothyroidism, but for years, women who were postpartum would come to the doctor, they'd say, I'm depressed, I can't lose this weight, I'm always exhausted, and it's kind of, there, little girl, you just had a baby, everything will get better in a year or two, or maybe in 17 years when your child grows up and leaves home. That historically was kind of the way things were treated, but now we're really recognizing this inflammatory nidus. As much as you love that inflammatory nidus, that's the baby. That inflammatory nidus can be very stimulating and can be a hyperinflammatory stimulus that then promotes this basic autoimmune disorder that is hypothyroidism. Now, myxedema coma is the worsening form of hypothyroidism, and this is, I always say this because this is one of the first times I saw myxedema coma, and it wasn't in the South, that was in Boston when I was at Mass General. Mama won't wake up. We went to Mama's house this morning. We couldn't wake her up. Called EMS. EMS brings her to the hospital. Of course, the first thing you're concerned with is Mama's had a stroke. But Mama also can be in a coma because of undiagnosed hypothyroidism. Now, it's relatively rare, but it is a significant endocrine emergency, and mortality rate approaches around 60%. Okay, so typically patients don't actually present in coma. That's really at the terminal state. Typically, they have significant changes in their level of consciousness, and they're less and less awake, less and less able to communicate, very lethargic, and ending up with significant obtundation. But it tends to be progressive. Doesn't mean it progresses over weeks, but it does progress over time. Typically, what we see is somewhere between 3 to 4 days, increasingly withdrawn, increasingly sleepy, increasingly confused, and ultimately slipping into a coma. Now, we know who we're going to suspect, right? We're going to suspect anybody with thyroid surgery who received any radioiodine, but we also want to recognize that you have a very common stimulation of inflammatory response that ends up with hypothyroidism, and that can be exacerbated in patients who have severe sepsis, particularly as it relates to pneumonia, in individuals with big MIs, patients with hemorrhagic shock, particularly in the gut, and also with patients who've had very potent diuretics. That's actually quite common. Myxedema coma, extreme hypothyroidism, everything is slow. So again, you may be semi-comatose or comatose. Your reflexes are really delayed. Nobody's measuring a reflex in an ICU. What we're going to look at is that hypothermia, bradycardia, hypotension, hypoglycemia, hyponatremia, and hypoventilation. Everything is low and slow. Yeah, you might have dry, coarse skin. You're in the ICU. I'm not really looking at whether your skin is soft and supple or dry. Your voice may be hoarse. I may not be able to hear that. And your hair is thin and dry. That probably describes a lot of people you think about. So again, hypothermia, bradycardia, hypotension, hypoglycemia, hyponatremia, and hypoventilation. The three key diagnostic features here: altered mental status, absolute or relative hypothermia, and a pre-existing illness. Those are really the key diagnostic features. They're pretty straightforward and they help us a lot. How low can they go? They can go pretty darn low. Okay, so typically with mixed edema coma, your free T4, this is good enough. T4 and TSH are fine here. T4 is low, TSH is high. Problems at the thyroid gland, your pituitary is responding appropriately. If your T4 is low and your TSH is low, you're now going to consider that this may be central pituitary hypothyroidism. But by the way, ultimately, that also is going to look like euthyroid 6 syndrome. So when you see that T4 is low and TSH is low, by the way, you cannot just accept those labs. You've got to ask your colleagues for a free T3 and a reverse T3. Because T4 and TSH, both being low, can either be central pituitary hypothyroidism, problem at the pituitary gland, which can happen when patients are septic, or it could be euthyroid 6 syndrome. And there is a difference between the two, because this one I'm always going to treat. This one I'm going to treat the precipitator and probably not the patient with thyroid hormone. At this point in time, typically we say don't treat the patient with thyroid hormone. So it is essential to differentiate this, although both patients are going to be behaving like they are hypothyroid. The diagnostic significance is pretty strong here. Okay, so hypothermia, hypotension, bradycardia. Usually the EKG is very low voltage, a very small, and you're thinking, oh, let me turn up the gain. Oh, I can see a bigger picture on my monitor, but the patient's voltage is very low. Remember that they're going to have hyponatremia. It's really a low sodium. And that's really going to be one of the biggest, most important diagnostic significance. Okay, again, weight gain, fatigue, weight, weakness, constipation, sort of things that you might not be thinking about in critical illness. Take a look at this patient's voltage. Look how tiny their R waves are here. This is low voltage. When you first looked at that, you might have said, oh, this looks like somebody with a pericardial tamponade or a cardiac tamponade, a pericardial effusion or a cardiac tamponade or a hemothorax, the heart going farther and farther away from the chest wall, and I'm seeing something small. And you would not be wrong, because in mixed edema coma, you actually are going to have a lot of fat and fluid accumulation that's going to be around the heart, separating the heart from the chest wall. And that's one of the reasons that you see that small, low voltage. Here's the thing. If we don't recognize this, we just think we've got a patient with refractory hypotension who's bradycardic, we're given atropine, we're given epi, we're on norepinephrine, epinephrine titrating up and titrating up. We're not actually thinking about what's occurring here. And again, remember, this is the far end of the continuum of hypothyroidism. The mortality is going to be very high. It's only up to a 50% mortality. Early recognition therapy is absolutely essential. And typically, this whole thing will be reversible once we initiate thyroid hormone. But remember, we really want to have a diagnosis of hypothyroidism. So we're going to look at T4, TSH, and if both T4 and TSH are low, we've got to look at free T3 and reverse T3. So that's not standard on your thyroid panel, but it is a standard lab that your lab can do. We just expedite by doing TSH and T4. The problem is that when those things look normal or those things low, we generally jump to a conclusion that either the thyroid is normal, or when we see that they're both low, that we should be giving thyroid hormone. In either case, we would not always be right. So we want to be sure that we appreciate that. Now, if you actually have significant hypothyroidism that has lent itself to stuporous, obtunded behavior, we're going to give you, of course, thyroid hormone. And we're going to load you with levothyroxine, which is a basic active form of thyroid hormone. And typically, we're going to give you about 300 micrograms. And then we're going to put you on a daily dose. That's going to be IV. IV, obviously, it does not communicate directly to oral therapy. It's going to be much more significant. It's a higher level and a higher load. Okay, so let's just look at our lab values when we're thinking about the thyroid gland and critical illness. I want to make sure you appreciate what I've said. You can't survive critical illness if you are hypothyroid or hypothyroid. Nobody knew you had thyroid disease before you came to the hospital. Maybe you didn't. Maybe it's what's put you over the edge is the hyperinflammation or the surgical intervention or the nidus of inflammation like a fetus or a wound that has put you over the edge. It's our responsibility to always consider that you have a thyroid dysfunction. All right, so if the problem is at your thyroid gland and you are behaving like you're hyperthyroid, you're tachycardic, you're hypertensive, you're hypoglycemic, you've got some other problems, we're going to take a quick look at you at this point, and we're going to see that your free T4 is up, which means your thyroid gland is over-responsive. Now, if the thyroid is the problem, free T4 and T4 will be elevated, but the TSH will be low because the pituitary is like, thyroid gland, stop releasing thyroid hormone. TSH is low. If you are hyperthyroid and the problem is the pituitary, you're going to see that the TSH is not behaving as it should. Your T4 is high, your pituitary gland should stop stimulating. But if the pituitary is stimulating and your T4 is high, this is a pituitary problem. Now, this is going to help us diagnostically. It's going to help us with intervention. It's going to help us make good decisions. And it's going to help us to look at other kinds of problems because, by golly, if you got a problem with your pituitary gland, you're going to have other things like your adrenal glands and your glucose metabolism. You're going to have other problems, vasopressin, because all those things are regulated by the pituitary gland. Okay, with hypothyroidism, if your FT4, free T4, is low, and the problem is your thyroid gland, your pituitary gland should be in overdrive stimulation. A very high TSH with a low free T4 means that you have a thyroid problem and it's hypothyroidism. Whereas this should say pituitary. I'm so sorry, it says thyroid. Sometimes when I'm writing my slides, I'm doing them really fast. Okay, so if you have hypothyroidism and it's pituitary, your FT4 is down, which is unresponsive, but your pituitary gland is not stimulating. So both of these are low. Now remember, I want to remind you that none of this will be 100% reliable in euthyroid 6 syndrome or non-thyroidal disease, okay? In thyroid disease or pituitary thyroid disease, this is very predictable. It's beautiful because you're saying I've got a primary organ, that's the thyroid, and a secondary organ, that's the pituitary. But the pituitary stimulates the thyroid. So I look at the hormonal output from the thyroid, and I look at the control or the stimulation from the pituitary gland. Pretty straightforward. It's all straightforward except in euthyroid 6 syndrome. Okay, so again, we just take a look at our lab investigation, TSH, free T4, free T3. Overactive, hyperthyroid, serum TSH is down, free T4 is up, free T3 is up. My thyroid gland is going wild, and the pituitary gland says, woo, calm down, calm down, calm down. That's primary hyperthyroidism. Primary hypothyroidism, free T4, free T3, down, down, down. And the pituitary is, wake up, thyroid gland, stimulate, stimulate, stimulate. Well, this is really straightforward. And it's really straightforward when the problem is at the thyroid gland, not the pituitary gland, and when we're diagnosing thyroidal disease. But remember, we're going to look at pituitary function, hypothalamic function, pituitary function, and end function when we're evaluating patients. So I've got 3 more slides and then I'll be done. So in euthyroid 6 syndrome or non-thyroidal illness or inflammatory syndrome, this actually results in the conversion by deiodinization, in conversion of free T4 to reverse T3. Now, reverse T3 is not going to be biologically active. Only the free ones, free T4, free T3, reverse T3 is not biologically active. So what you're going to see, the number one thing you see when diagnosing these patients, they look and behave hypothyroid, but it's not the thyroid hormone, it's the conversion of free T4 to reverse T3. And it really occurs. Some studies say 86% of critically ill patients have euthyroid 6 syndrome. And if all we're looking at is TSH and T4, we're not actually seeing this. We're not diagnosing it. It can occur whenever you've got an iodine load. Big medication, of course, is amiodarone. Another one is glucocorticoids. It also can occur when you have diabetic type 1 or type 2 diabetes, in either case, okay? And always want to consider this when my patient's on these medications, right? When they're on glucocorticoids, when they're on any iodine base, and particularly when they're on amiodarone, which is one of the most common agents that we use in critical care today. So pay a lot of attention, okay? T3, T4 are not helpful. If you're going to see something, T3 will drop first, and ultimately T4 may decrease. TSH stays low to normal. TSH doesn't go up. So it's not really very, very helpful. So really a couple important things. I copied this from a beautiful article about when to be suspicious, okay? If you think that the patient is not behaving appropriately, that you're not able to control their heart rate, you're not able to control their blood pressure on either side, you should consider taking a look at thyroid function, okay? When you look at TSH, you want to remind yourself that TSH is like, you're looking at that TSH measurement as necessary when patients are really sick, and that these limits, their detection limits are really, really low, and you're going to use that. But here's the problem. Measuring TSH alone is inadequate overall when you have a critical patient who has symptoms of thyroid dysfunction. So really, really important. What we should always think about in our overall profile in any patient that we suspect of having thyroidal disease or euthyroid 6 syndrome is we need a bigger platform. So most patients, that would be TSH, free T4, and total or free T3, okay? Still going to be difficult to diagnose them. So what I want to remind you, T3, that T3 level is a really good predictor for how sick your patient's going to be. So you really want that T3 level. And again, you want free T3 and reverse T3. Those are really going to give us good information. And when we look at these patients who have euthyroid 6 syndrome, they almost 100% of time get missed, because all we're doing is looking at TSH or TSH plus T4, and that isn't going to give us the greatest information. We do know that when your T4 level is less than 3 mics per deciliter, that actually correlates to a mortality in excess of 85%. I love this graph so much. So here's your normal range of hormones, and you can see we're looking at the 4 different regulators of hormone: sick, sicker, and sickest. Such a great graph. Doesn't have to be too intensive. Okay, so what you see here is your patient's T3 drops very quickly and very significantly. TSH takes much longer to drop. You have to be between sicker and sickest for your TSH to drop, and the same with your T4. The earliest predictor of non-thyroidal illness, patient acts like, looks like, and is behaving like he's got thyroid dysfunction, and this would be hypothyroid, you're going to see that T3 go down, and it's going to go down pretty quickly. But the best predictor is the reverse T3. Now, remember what that means. Reverse T3 means that I'm reversing active T4, free T4, into reverse T3, which is an inactive form of thyroid hormone. So it's actually at the hormone level, not at the pituitary, not at the thyroid gland, but at the hormone level where you have this hypothyroid effect. It's not a failed thyroid, it's not a failed pituitary, it's a failure at the hormone level because we have reversed free T4 into reverse T3, which is inactive. And look at how rapidly that goes up. So you see this very early on with the sick patient. Now, you know what? I'm going to just say 50% of the evidence says treat it with thyroid hormone. The other 50% of evidence says don't treat it with thyroid hormone. Okay, well, we might not make that decision. That's going to be made by endocrinologists and our attending team. But if they don't know it, if they don't see it, if they don't recognize it, here you're looking at a patient who is hypotensive and bradycardic and refractory, and nobody has actually said the problem is their thyroid hormone. So quite honestly, most of these patients, if you give them thyroid hormone here, they're going to regain their heart rate, they're going to regain their blood pressure. The problem is, and that's always the problem, is that when we give our patients thyroid hormone, we suppress their innate thyroid function. And that's why there's so much controversy about treating your patients who have non-thyroidal disease or euthyroid 6 syndrome. I'm just going to mention to you, I think probably all of you have recognized that in the last 6 years or so, when you are doing preservation of organ in order to provide for organ donation, you always give thyroid hormone, because that actually increases the receptivity and the vascular tone and the cardiac contractility. But I think it is something to consider when we have patients who are refractory, even if it's euthyroid 6 syndrome, we may need to consider for a short period of time that we're going to initiate some thyroid replacement. Then you will have to put that on a thyroid taper, and you're going to hope that they're going to regain their normal thyroid function. But whenever we get thyroid hormone, we cannot do that without significant concern for the benefit versus the risk. And that's why there's so much controversy about whether or not to replace it. Another fantastic article, I'm happy to share it with you. This fantastic article looked at patients, in 340 patients who had that had history of thyroid dysfunction, or who did not have a history of thyroid dysfunction, but who actually were behaving as if they were hypothyroid, and the abnormalities in their parameters. And low free T3 was the most common abnormality. Patients had pretty normal, most patients had a pretty normal TSH and a pretty normal T4. Some of them had abnormalities, but very important to appreciate that our tests are misleading. This is why you need an endocrinologist, actually. And what I found is, even in my own hospital, endocrinologists are always ordering TSH and T4. And the problem is that if I have a patient now who actually is having issues with the metabolism of the thyroid hormone and that reversal from T4 to reverse T3, that they are going to behave as if they are hypothyroid, but their labs are going to look normal, the basic labs that we do, TSH and T4. And that, I think, my friends, is one of the most important things for us to hear. Okay, so we always want to remind ourselves that with patients who are not behaving the way they should, they're not tachycardic, they're not responding to our catecholamines, I think we should always consider the possibility of thyroid dysfunction. And when we think about that magnitude and abnormality of the thyroid gland and how important the thyroid gland is in response to catecholamine, in response to cardiac contractility, and response to the ability to our organ response to the physiology of the autonomic nervous system stimulation. So sympathetic, increase in the heart rate, increase in the contractility, increase in the vascular tone. We should always be thinking thyroid. Other things that can present this way: pure hypothyroidism, acute exposure to heat, fasting and starvation because of free fatty acids. So these are other things that can give us abnormalities in our thyroid hormone. Of course, no surprise that hypothyroidism is going to give you low T3, low T4, high TSH, and a low corticosteroid hormone. All right, my friends, I hope that you feel like you've learned something. I think this is like one of the most important topics, and I'm so grateful that you were able to spend the day with me today in this hour on the Tuesday topics. Today, looking at thyroid hormone and critical care. I'm going to sign off from recording, but I will stay online in case there's any questions. Thank you very, very much. Bye-bye for now.